Okay, so we'll get started. So everyone here knows me. I don't have to introduce myself, but for the podcast, my name is Vivian Vega. I'm one of the second-year fellows. And I'm going to talk to you guys today about clinical immunology for ID. So basically the thing that we hoped we never had to really discuss ever again or remember, but we do. And actually, that's the reason I picked this topic, is because I was the least familiar with it. I felt like I needed a lot of work at this, even though we may not see it as much. When it does hit you, you better be ready for it, kind of thing. So these are the objectives for the talk. So we're going to discuss sort of the patient with recurrent infections, how they present, what things to look for. We're going to go over primary versus secondary immune deficiencies. The secondary immune deficiencies you guys are more familiar with. I'm just going to sort of mention them, but the primary ones are the ones we're going to discuss in more detail. And then we're going to talk about when to suspect that there may be an immune deficiency, what kinds of things to look for in these patients. And then we'll go into the types of these primary immune disorders. We'll talk about how they present, how to diagnose them, what things to look for, how to treat, which the treatment's going to be more of an overview. It's very similar, as you'll see. We get a lot of questions on the in-training exam about this, so that's another reason that triggered this for me. And a lot of you already need to know how they present, and then they're going to ask you to pick how to diagnose it, what test to order. So basically, the patient with recurrent infections presents a problem. It can be very difficult for the general practitioner to sort of determine what's going on. So eventually they may get referred to us, they may get referred to the allergist and immunologist. Either way, we'll be ready for it. So in most cases, there's a secondary cause for their immune deficiency. So whether it's an anatomic abnormality or secondary immune defect. So as far as anatomic, these can be congenital or acquired. So things like polyps, nasal polyps giving you recurrent sinus infections, patients with lymphedema or venous insufficiency presenting with recurrent cellulitis. That's what we mean by anatomical, like mucus seals, et cetera, et cetera. Secondary immune defects are the ones we're familiar with, and I'll show you what those are. And the primary immune defects are the ones that I'm going to focus the talk on. And even though these are rare, they're actually more common than what we think, and there's more and more evidence that they're more prevalent than what was previously thought. So these are the secondary immune deficiencies. These are the ones we're used to dealing with. So the most obvious one, diabetes, that we deal with on a regular basis, cirrhosis, the hemoglobinopathies, HIV, of course, nephrotic syndrome. And with nephrotic syndrome, a lot of the other protein-losing states, so if you go to the bottom here, enteropathies, severe exudative skin disease, peritoneal dialysis or hemodialysis, splenectomy, neurological disease, malignancies, etc. And then at the bottom here, these are the more obvious ones, right? So immunosuppressive agents, glucocorticoids, or the immunomodulatory agents like rituximab, the anti-TNF inhibitors, etc. So these are the ones we're used to, and these are the ones that if there's no anatomic pathology, there's no secondary immune defect, then we're looking for the primary ones. So prevalence is actually more than what we used to think. So 1 in 1,200 people in the U.S. This is actually tenfold higher than what was previously thought. Some of these can be mild or moderate in clinical severity, so they'll actually present in adulthood. So it's not just a disease of pediatrics. They can, like I said, routinely escape detection. So then it'll be something that we're going to be dealing with. This was published in Journal of Clinical Immunology in 2007. So basically, a conclusion that they're a lot more common than was previously thought. So something to pay more attention to. So when to suspect primary immunodeficiency. So, and this is sort of where you get tested, right? The moment of truth is being able to identify this patient. So some of the warning signs are going to be 4 or more infections that require antibiotics within 1 year. And these infections are going to be sinusitis, bronchitis, pneumonia, otitis, etc. Recurring infections or infections that either did not respond to prolonged antibiotic therapy or they required prolonged antibiotic therapy. So either or. 2 or more severe bacterial infections, such as osteomyelitis, meningitis, septicemia. So that's weird, right? Somebody that's immunocompetent should not be having recurrent meningitis or recurrent bacteremia. So that's something that will trigger you to think, even osteo. And we're talking no trigger, so no hardware, there's no reason for them to have osteomyelitis, no IV drug use, etc. Or 2 or more radiologically proven pneumonias within 3 years, and specifically if they had to be hospitalized, they required IV antibiotics, it took them forever to get better, or it had intrathoracic spread, or necrotizing pneumonias, etc. More warning signs. So basically, if you find a bug in a place where you shouldn't be finding this bug, that should kind of trigger a red flag. So that's what that means by infection with unusual localization or unusual pathogen. Recurrent deep abscesses of the skin or of the lymph nodes shouldn't be happening in immunocompetent. Chronic diarrhea with weight loss, especially if you see a lot of campi or cryptosporidium. Somebody presenting with persistent thrush, but they haven't received steroids, they haven't received antibiotics, so why is this happening? Recurrent or prolonged unexplained fevers. And of course, if they have a family history, that sort of kind of will give it away a little bit more. So they're going to exhibit poor wound healing. So if you see somebody that has no good reason for why their wound is not healing, this is also seen with neutropenia. Premature loss of adult teeth, severe gingivitis, really bad periodontal disease. That's also unusual. You can see with these disorders, and we'll go into that a little bit later. And then unexplained bronchiectasis, right? Bronchiectasis is usually a result of recurrent infection. So why is this presenting like this? And then some things to keep in mind is, so you have a problem with the immune system. Your immune cells are in charge of a lot of different things. If you have impaired immune system, you have impaired inflammation, so they're not going to present just like everybody else, right? So they may not actually mount a fever. So they're going to be a little bit more difficult to identify. So they may feel fine, they can't even tell you that they're sick. Oftentimes they're actually way sicker than they look. They'll have more extensive disease than what appears to you on the surface, and they'll definitely require longer treatment. They're going to have more of the unusual infections. So like I was alluding to, fundamental function of the immune system, so it's not just to sort of defend yourself, but you have to be able to identify self from non-self, right? So a bacteria is non-self, a virus is non-self, so you're looking for those. Malignancy, be able to detect malignant cells, that's also a feature of your immune system. And recognizing self is going to prevent you from having autoimmune disease. So this is also sort of associated with your immune system functions. So not surprisingly, you're going to see that a lot of these disorders are going to be associated with autoimmune disease or malignancies. Another manifestation of immune dysregulation is going to be allergy, so that's also why they're linked together in many instances. Some of the autoimmune disorders that you may be able to see are autoimmune thyroiditis. In internal medicine, we were kind of taught to make associations with vitiligo, celiac disease, pernicious anemia, the thyroid disease as well, and then hemolytic anemia, thrombocytopenia, and those things. As far as inflammatory diseases, arthritis, inflammatory bowel disease, connective tissue disorders, all those can be associated with immunodeficiencies as well. And it's not just once they're treated, but even just associated with them prior. So the first thing and sort of easiest way to organize it for me is to look for which part of the immune system is affected. And then you kind of look for a pattern, and you know if this group of cells or that group of cells can help you start to evaluate the patient. So with immunoglobulin defects or complement defects, you're going to see a lot of recurrent sinopulmonary infections, infections with encapsulated bacteria. With the complement defects, you'll see like the bacteria and the meningitis. Maybe that kind of rings a bell from internal medicine. And then you'll also see Giardia, Cryptosporidia, Campylobacter causing GI disease, diarrhea, chronic diarrhea, etc. For granulocyte defects or neutrophil defects, you're going to see more recurrent invasive skin disorders, soft tissue infections. You're going to see a lot of abscesses needing recurrent IND. Mainly going to be Staph aureus and gram-negative bacteria, which makes sense if you think of your neutropenic patients. Nocardia, Aspergillus, etc. Then cell-mediated immunity is probably going to be the one that I'm going to talk the least about because it's the one we're most familiar with. If you think about your HIV patients, you'll have progressive infections with benign, what are ordinarily called benign viruses, CMV, BV, herpes viruses, etc. You're going to have mycobacterial infections, fungal infections such as Candida, Crypto, and PCP, which, like I said, we're familiar with because of our HIV population. And these are primarily going to be defects of T cells. So what are the types of immune defects? So we're going to go one by one down this list and sort of give examples and cases and hopefully help you kind of remember and stick. So we'll start with complement. And we're going to discuss in detail the entire complement cascade. Just kidding. But basically the main thing... The main things I wanted to point out here is the lectin pathway. We're not going to say a whole lot about it. It's very mild. It's usually in infancy. It doesn't really have much of a role for adults. But we'll talk about the classical and the alternative pathway. So the main things, the classical pathway is antibody dependent, meaning you have to have seen the antigen before you have to have been exposed. So it really doesn't help you with a new exposure. It's not very efficient with new infections, right? So that's why you have the alternative pathway, and this one's directly activated by the antigen or the protein itself. Bacterial cell wall, for example, etc. So it can be directly activated. And really the main thing here, a bunch of things happen, and then they all converge at the one important piece, which is the membrane attack complex, and we can just go from there. So the main things, classical pathway, these are, most of the complement deficiencies are autosomal recessive. Like I said, it's antibody-dependent bacterial lyses. And this is going to present with the recurrent bacteremia, recurrent meningitis with Neisseria, which is the one that we're really familiar with, I think. And the alternative pathway, like I said, is antibody-independent, so it can be directly activated, and it's going to have more severe defects. So like I said, late complement is going to be these recurrent bacteremias and meningitis. This is so that you remember, because it was definitely a question. Age of onset is usually 17 years of age, but the presentation is going to be more mild. Like I said, inflammation is a sort of a double-edged sword. So if you think of an impaired inflammatory response, then they're going to have less symptoms and be a lot more mild in their presentation. And then the early complement cascade is more associated with autoimmune disease. So somebody presenting with any of these things, and you're, oh, I know this. This is a complement deficiency. So you just have to pick the right test to order. So to diagnose, classical pathway is going to be CH50, and that's the one that they usually ask about with the Neisseria and the bacteremia. And treatment for these patients, and an alternative pathway is the AH50. This is a red blood cell test. And the treatment for these is obvious. You treat the infection, but you also just start prophylaxing, and there's a lot of literature on hypervaccination for these patients. So moving on to antibody deficiencies, we'll talk about IgA deficiency, and this is the most common antibody deficiency. It's about 1 in 700 patients. And I'm going to call this sort of the gateway defect, because really it doesn't have much of a, doesn't cause much of an issue, but it's something that if you see it, look for other things, especially common variable immunodeficiency, because it's going to come with something else. By itself, it may go unnoticed, so to speak. But then just look for other disorders. And as you can imagine, just for diagnosis, you'll just see low IgA levels. So this brings us to common variable immunodeficiency. And this is going to be the one that you're going to see the most in practice. And basically, it's defective immunoglobulin production. So you'll see markedly reduced concentrations of IgG, but it's almost always going to present with low IgA and low IgM as well. The key to CVID and the key to diagnosing it is that they have poor or no response to immunization, and I'll talk about that a little bit more. And then to say that it's CVID, there has to be no other immune disorder present. So CVID, again, recurrent sinopulmonary infections, right, because this is under the immunoglobulin defects. Pneumonia, bronchitis, sinusitis, etc. It's usually going to be with the encapsulated bacteria, so strep, H. flu, more atypical bacteria like Mycoplasma species. they're going to have a lot of chronic enteric infections with Giardia, Campi, Salmonella. The GI stuff is going to be a lot less than the top two things, but it's definitely something, and about 30% of patients are going to present with these chronic GI infections. And then even less are these severe echoviral infections with meningitis and encephalitis. And then something with CVID patients is that they have a much higher rates of autoimmune disease and malignancy, especially non-Hodgkin's lymphoma. So just a couple of pictures. So basically, to show you these recurrent sinopulmonary infections and what I mean by that. So obviously some acute sinusitis, a lot of fluid there in the sinuses on the film, and then you see it anatomically, and just sort of another cut here. And this is now when ENT is actually going in there and seeing it. So then what do recurrent infections do to your lungs? And we kind of alluded to that earlier in our broad right. So you get bronchiectasis. And so that's just what happens with bronchiectasis. So you get infection after infection, so you get a lot of scarring, so your bronchioles get really thick and they widen, and there's a lot more mucus that can go into them if you want to think about it that way. So that's why they have recurrent, a lot of cough, a lot of hemoptysis. And bronchiectasis is more typical of the lower lobes. So that makes sense, right? I mean, I've showed you that picture, so you see that, you'll see that peribronchial thickening with bronchiectasis if you look at the anatomy. And you can see the widened airways, almost look like emphysema on this one, but just that thickening around it, plus now they're really wide. You can also see lymphoid hyperplasia on when they scope these patients. On histo, you're going to see abnormal villi, and like I said, chronic diarrhea is going to be the most common presenting GI symptom in these patients. GI symptom, not. So again, how do you diagnose CVID? So the more obvious thing, low IgG levels, right? And it's not just total IgG, but all the subclasses are going to be low as well. And then it's almost always going to be associated with low IgA and low IgM as well. But really the main thing, and the board questions may focus on, is going to be failure to respond to new or recall immunization. So in other words, you vaccinated them, but they never mount a response to the vaccine, right? So the way to seal this diagnosis is really to assess for that response. So you have to vaccinate them, you check their antibody levels, then you vaccinate them, then in 2 weeks you check them again, and that's how you can say, absolutely, this is, I have my diagnosis because they did not respond to this recall immunization, right? And you check both response to protein-based vaccines and to polysaccharide-based vaccines, so you vaccinate them with these. And then as far as treatment goes, again, more of the same. You treat the infection, obviously. You can give them IgG immunoglobulin replacement. And then ultimate cure is going to be bone marrow transplant. So then a case to transition into the next topic. So this is a 23-year-old woman, athlete, in good health, basically, comes to the ER now with severe shortness of breath for 4 hours. She had just completed a 3-mile run. Comes to the ER, feels like chest pressure, really short of breath. ER does their evaluation. They think it's anxiety. She just went out with her friends in New York. Who knows what they were thinking, so they sent her home. This was a real case that I kind of took from somebody. But so she goes home, comes back in 2 days. Now she has a fever. She's a little hypoxic. They do a little bit more of a history. She has these recurrent respiratory infections when she was little, and then this random history of cat scratch disease. And they get another x-ray, and now her x-ray looks like this. So they start her on broad-spectrum antibiotics. They add steroids onto that, right? That looks almost PCP-ish if you were to take them. Another day goes by. She's not getting any better. She ends up intubated. Worsening hypoxia despite all this treatment. They bronch her. They don't really find anything. All the bronch studies, preliminary studies are negative, still not improving. They scan her chest, kind of looks like this. And then eventually she undergoes VATS with a biopsy and turns out to be Aspergillus, right? In a previously healthy 23-year-old who just ran 3 miles, right? So, and the main thing I was getting at with this question is, so if you see invasive aspergillosis in somebody who they told you is completely healthy, what is the most likely defect that you want to think of in this case?
Probably so that was like, because if you have skin, you would present that as a child, right? The first one is an allergy type thing. So
Right, so it's probably not A, right? Plus I, they would with A they would have given you some other history of allergy, or maybe throw some IgE in there. Right, B is not. So who gets invasive aspergillus other than normal? You know, not usually normal patients. Who gets it? Neutropenic patients. So which one is a neutrophil? Right, phagocytes. Right. So that's a neutrophil. That's in the group of neutrophils. So right. So it'll be D is the answer.
It's myelocytes.
But it's in the group of phagocyte disorders, right? They kind of. So this is a little introduction into chronic granulomatous disease, right? So basically, it's a deficiency of the reduced NADPH oxidase. This is responsible for respiratory burst and generation of hydrogen peroxide. And this is just kind of a fancy way of saying that this is what neutrophils need to. So neutrophils is like Pac-Man, right? They just like swallow the antigen and then they have to kill it somehow, right? So this oxidative metabolism is what helps you activate the neutrophils and kill whatever they ingested. So problems with this leads to recurrent life-threatening infections, like we just gave the example of this 23-year-old girl. Bacteria and fungal infections mainly. They can also have dysregulated granuloma formation. Usually they'll present in childhood, but there's a lot more cases presenting in adulthood now. Like you saw, she was 23 years old by the time she presented. So the interesting thing about CJD is that has a really kind of specific array of organisms that are pathognomonic for CJD. So if you see, and I'll give you some of the scenarios, but a lot of Staph aureus, but it's going to be Staph aureus in places where you wouldn't think Staph aureus should be. If you see a Burkholderia saponaceae bacteremia, you got to be thinking in a otherwise normal patient, you have to be thinking CGD, serratia, nocardia, and then Chromobacterium, and like I said, Burkholderia. If you see these frequently in patients, then it strongly suggests the diagnosis of CGD. And then if you see if they throw you an Aspergillus nigilans pneumonia, that's also strongly associated with CGD. And in these patients, it presents much more aggressively and needs more intensive treatment than Aspergillus fumigatus. So, like I was saying, you'll see these are your CGD bugs, right? So starting with Staph aureus, but you'll see Staph aureus in the liver, in the lymph nodes, a lot of osteo out of nowhere, serratia marcensis, skin, lungs, lymph nodes. Like I said, Burkholderia bacteremia, if you see that should trigger some buzzwords there, associations. Nocardia is pretty typical, the same way we see it in immunocompromised patients. Aspergillus, but you'll see like the lady in the case, disseminated Aspergillus out of nowhere in a person who was completely immunocompetent. And then these last four that I highlighted are your pathognomonic organisms for CJD. So Chromobacterium biolation. So all the ones that you can't really pronounce are the pathognomonic ones for CJD. Chromobacterium biolation. This was interesting. At the board review, they told us, think of this in Florida, warm brackish water, Disney, blah blah blah. I was like, what are people doing in Disney? I mean, it's like Splash Mountain, maybe, I don't know. So just remember that, and then yeah, not kept. Yeah, definitely brackish.
Disney World is built out of a swamp, so.
Yeah. Francisella filomorrhagia, also associated with brackish water. Burkholderia gladioli, which they made a big deal about this causing onion rot, how that's relevant to humans, but in humans it'll present with pneumonia usually, but I guess it's another way to kind of remember it. And then Philomyces species. Then, not as common as what I just mentioned, but you also see with CGD a lot of GI involvement and pretty much everywhere in the GI tract for the most part. And just to note here that gastric outlet obstruction may be a common manifestation and may be the sort of initial manifestation with some of these CGD patients. So what are we looking at here in the top? Yeah, liver abscess, exactly. So liver abscess, and then you open it up and it looks like that white, chalky, hard, dense, like you try to drain it and it doesn't really drain liquidy. You have to resect the whole thing. So that's not your typical abscess, right? A typical abscess, you're going to drain it and liquid's going to come out, and it's usually gram-negatives or anaerobes or whatever. But if you see randomly somebody who was previously found presenting with a Staph aureus abscess, that should raise suspicion about CGD. So basically, you shouldn't really be seeing staph unless they were manipulated or something like that. And then, like I mentioned, the Aspergillus nigilans pneumonia, that's also pathognomonic for CGD. Huh?
That looked like pneumonia.
Yeah, exactly. There's a lot of circular. They also have a lot of issues with wound dehiscence. So one of the little cases they gave us at the board review is, you're always kind of fighting with surgeons about, no, this is infected. You really should take a look at this. It looks infected. And wound dehiscence is usually a sign of infection, right? So you want to culture and treat them with antibiotics and see what you have. So in these patients, you actually treat the wound dehiscence with steroids. So that's even more of a difficult case to find. He was talking about how the surgeon came up to him this time, and the surgeon was like, no, I really think it's infected. I really need to give him antibiotics. And he's like, actually, because of this history, in this case, you treat the inflammation, so you treat with steroids. So issues with wound dehiscence, more pictures of fungal pneumonias, like I said. So now we already talked about complement. You do the CH50 for diagnosis, because again, these were the million questions that I missed in training exam. But it's really easy. It's really easy if you just look at this and put the patterns. There's like 5 things that you just write down, and that's it. You'll get the questions right. So CGD diagnosis is you do this nitroblue tetrazolium reduction test, right? And I think somewhere back there, it's, yeah. So there you go. Then you're bound to get one right, exactly. This bottom one is a newer test, but it's not going to be on boards yet, and it's not in every lab right now. So how do you treat these patients? You try to prophylax, and you prophylax with both antibacterials and antifungals, which are the most common things. So usually they're on Bactrim and they're itraconazole. There's a lot more evidence for the Bactrim and the antibacterial prophylaxis than there is for the itraconazole, but they still do the itraconazole. And then a lot of patients are treated with interferon gamma as well. And then, like with most of these things, the ultimate cure is going to be bone marrow transplant. So moving on to leukocyte adhesion disorders. So basically, there's these molecules, and I'm going to quickly do an overview of these. So there's these molecules called integrants and selectants, and they basically help the neutrophil attach to the endothelium, right? So it helps them attach to bacteria, it helps them attach to other lymphocytes, it helps them attach to the endothelium, right? So they kind of attach and they roll and they inspect everything, like if you kind of picture it like that. And then there's those little gaps in between your endothelial cells is how they kind of roll, and then that's how they get into the from the intravascular space out to the extravascular space, and they get to the tissues, right? So like if you cut yourself on your knee and you need pus and a scab and all that, that's how this is happening, right? They need to actually get there to cause the inflammatory response. So patients that have these defects, and so that's a beta-2 integrin over there, and that's a CD18, it's a complex. So if you don't have that, you can't attach, you can't roll, you can't go into the extravascular space, basically. And that's what I'm talking about here. So the bold parts are the things that may be asked, because this is how you diagnose it, right? So you do flow cytometry for CD18. So if you can imagine, the neutrophils are not getting out into the extravascular space. They're all staying intravascularly. So these patients are going to present with a white count of like 20, 30, 40. They're usually at baseline 20s and 30s, even when they don't have an infection. So maybe they'll go from 20 to 40 when they actually have an infection. But it's all circulating and nothing really gets to the tissue, so it's not doing any other work, right? So they're just kind of all hanging out up here, but not really getting anything done. Kind of like a congressional meeting. Just kidding. So if you go, you can't put the neutrophils into the tissues, right? So they get really nasty periodontal infections. Most of these patients will lose all their teeth by the time they're 12 or 13, right? Because if you can't, so all of us will have a bunch of neutrophils in here fighting the bacteria so that it doesn't take over. So here, that's not happening. So eventually, everything rots out, and it initially looks like that. And most of them, like I said, will lose their teeth. They also present with really bad skin ulcers, and these are usually present for a while. They can look like this, and they can stay like this for some time until they're treated, but they can also eventually, they almost look like ecthyma gangrenosum or pyoderma, and they can be pretty bad. And I read a couple of cases where this disorder was diagnosed based on recurrent pyoderma gangrenosum presentations. So this was actually published in India, this particular study with this picture. So like I said, so this poor inflammatory response, so then it leads to all these necrotizing infections, usually gram-negative rods or gram-positive cocci, never fungus or candida. So if they're giving you a case with fungi or candida infections, it's not going to be this. It's usually going to be the things that I mentioned. Like I showed you in the picture, the cutaneous lesions may look like ecthyma in the beginning and maybe pyoderma. The people who survive infancy will develop really bad periodontal disease. Like I said, they'll lose their teeth. And with this particular disorder, there's frequently a history of consanguinity. This is why I was saying it's good that Dr. Tony's not here. This is one of my favorite T-shirts. So West Virginia, there's no lifeguard in the gene pool. That's okay. It's just for the people that are falling asleep. Yeah, no. So, no disrespect, Dr. Tony. Yeah. So, right. He makes fun of everybody. So basically, the defect here is going to depend, or the severity is going to depend on how much of the CD18 you're lacking, right? So if it's a severe deficiency of these integrins, then it's going to be your more severe one. And this is kind of a buzzword for LAD. They're going to present with delayed umbilical stump separation. So you can't get neutrophils in there to kind of chew that out, then it doesn't happen, right? So the periodontal pictures that I showed you, hopefully you won't forget that. Loss of dentition and alveolar bone. And some of these things we kind of already talked about. So a lot of the questions, one of the questions on our board review was they showed you this patient and he's totally acting like LAD. What is the thing that is going to help you diagnose it? You do a biopsy and there's no neutrophils. So it's like this nasty skin ulcer and you biopsy it, but there's absolutely no neutrophils. So that's how you know that it's... and then we can probably just kind of skip through this. This is more talking about more moderate deficiency. Then they may not necessarily always present with that umbilical stump separation. But they're always going to have this leukocytosis, like I said in the beginning. They're always going to have this chronic 20,000, 25, 30,000 leukocytosis. So diagnosis again, for the highlights, you do flow cytometry for CD18. That's a defect there. There's some other complement studies, but they're more complicated. We'll just stick to the CD18. And then again, treat the infection, transplant for cure, but again, transplant's hard to do with these patients. So myeloperoxidase deficiency, I'm just going to mention one slide on this. It's kind of fairly straightforward. This is the most common neutrophil disorder. It's 1 in 2,000 persons. It's usually silent, which is why I don't want to make too much of it, but it's something that is out there. It's on Mendel. It's on the board review, so just we need to know it. It usually doesn't cause any problems unless there's a secondary immune disorder, and it's usually been associated with diabetics. So if you're a diabetic and you have this deficiency, then you may present with these worsening infections, so recurrent candidal infections. But not a whole lot to do. You just treat the candidal infections. There's no prophylaxis or anything for these people. So that's myeloperoxidase deficiency, and you just look for myeloperoxidase. So what do these kids and animals have in common? Yep. So albino dolphins. I've never seen one before. Huh? Yeah. Well, that's supposed to be albino. But yeah, basically. So this is going to be our lead into Chediak-Higashi syndrome. This is a pretty rare autosomal recessive disorder. It's caused by defects in this lysosomal transport protein. and that's going to be only important for diagnosis purposes, like I said. A lot of recurrent infections of the skin, sinopulmonary infections, and then this one's going to be a little easier to identify, right? Because I just showed you. So they're going to have this oculocutaneous albinism. A lot of them have some mental retardation, have photophobia, nystagmus. If they live into adulthood, they'll have a really bad peripheral neuropathy, and all having to do with the same mechanism here. So many of them will die in childhood, but there's a larger number that are living into adulthood and late adolescence. And the way to diagnose it is you look at the peripheral smear and you'll see all these large giant lysosomes, which I'll show you. The other way to diagnose it is to look at their hair and the shaft of their hair. The melanin distribution is a lot different. So basically, that's normal hair on the top, and this is a Chediak-Higashi hair shaft. So this is, that's a person with really dark hair, obviously. So the melanin, if you can see, it's kind of evenly distributed and linear. This one's really clumpy and it's kind of all over the place. So people that know how to diagnose it, they'll just look at that and they'll make their diagnosis based on that. And it causes like this silvery sheen on their hair. And then, but the easiest thing, obviously, you look at the peripheral smear, and you may find one of these neutrophils. And the things that are abnormal about them are these large cytoplasmic inclusions. So you're looking at the smear. That's a normal neutrophil over there. That's an abnormal. This is the Chediak-Higashi neutrophil with all those little sort of balls on the outside. So it's a defect in a transferring enzyme. So basically the lysosomes can't get rid of these things, so they just blow up. So that's why they look like that. So last one, almost there. So this is going to be a case of a 27-year-old woman with recurrent boils. She gets sent to your office for evaluation. They're usually Staph aureus boils, and this really smart doctor that referred her to you already checked an IgE level. So the IgE level was really, really high, 13,000. And she's presenting with, prior to this, recurrent bouts of sinusitis, bronchitis at least once a year, persistent eczema requiring steroids. I don't know if anybody has any idea what this is going to be, because I wouldn't have, but okay. So, yeah, so that's pretty straightforward, right? Because they give you the IgE, right? So Hyper-IgE syndrome or Job syndrome. Main things are going to be these, again, recurrent sinopulmonary infections. So it's best to look at the things that differ in them, right? Because a lot of them have recurrent sinopulmonary infections. So these people are going to have pulmonary cysts. They're going to have all these characteristics that I'll show you that tell you this is Hyper-IgE or Job's. So it's a characteristic facies, which is this right here. They're going to have a very prominent forehead, these deep-set eyes, and a broad nasal bridge. And if you look at like 15 pictures of these, they kind of all look a little bit alike in some ways or another. So.
No, if I look at someone like that, I would not say that they look different than a normal person.
They don't? You don't? You wouldn't? No? Okay.
Why did they pixelate their mouth?
I don't know. I don't know. Maybe, yeah, maybe the baby was cursing.
Maybe you can look at them and say they have bad genes, they don't look good, you know, but not
yeah.
so that they look different.
Well, okay, but then maybe they'll also tell you this: delayed dental deciduation, which I learned is
Delayed falling of the baby teeth.
basically your baby teeth don't fall out, right? So you see the baby teeth hanging out back there and the normal teeth. And then, even if you've never looked at a dental film before, you can probably tell that that's way too many teeth in there, right? Too many teeth. And you even see some teeth under teeth, right? Still, so, I mean, but this is a more obvious one. They're also going to have this really high arched palate. Does that look abnormal?
Yes.
Okay. And then what are the other things that I mentioned before? So all those things, that they'll have a lot of eczema, they'll have scoliosis, they'll have frequent fractures, a lot of mucocutaneous candidiasis. And basically you make the diagnosis by IgE levels are going to be really, really high. And then it's caused by mutations in the STAT3 gene, so you can check for that as well. And same thing, treatment, you treat the infections, prophylax, antibiotics, and antifungals. Still nothing?
Push. If I was just, to look at someone like, I would think they have hyper-IgE.
So that's nice of you. And what else do you see higher arch palate with, just random? There's another condition that you see higher arch palate with. There's my favorite president had this. Marfan's. Yep, Lincoln's my favorite president. Yeah, so he didn't have Hyper-IgE, he had Marfan's. So you see a higher arch palate with Marfan's. Yeah. So just to kind of summarize, these are the big sort of things for the test. So you see recurrent bacteremias or meningitis with Neisseria. You're going to think complement, and you're going to order what? Yep, good. That was the first one, exactly. Perfect. Recurrent sinopulmonary infections plus mostly encapsulated organisms and some gut involvement. You really want to be thinking about CVID, and you order. Yep. And then what's the other thing that I talked about? How you seal the diagnosis with. Right, because they can't exactly. Right, because they don't have recall immunization. Invasive aspergillosis in an otherwise normal host. You think of phagocyte defects, and one of the ones I showed you was the CGD. Burkhold area, Cepacia bacteremia is pathognomonic. So were the Staph aureus abscesses that I showed. Strongly suggest CGD. And then delayed umbilical stump separation, if you see any of that mentioned, or the nasty grill. Think of LAD, and then PCP with T-cell abnormalities. So, and that's it. Thank you.